edit. Okay. All right, so chest tubes. Something that we don't get too often, but when we do, we get a little anxious about perhaps. I can see, okay. I have a lot of stuff going on here. Okay, go to the next thing. There we go. Okay, so today we are going to do a little bit, a little bit of physiology review, as we always do. We're going to talk about anywhere is fine. Chest tube indications. Why does a patient need a chest tube? We're going to talk about, and I am recording for anybody that just full disclosure. The insertion of the chest tube, if you've never had the pleasure. Chest tube maintenance, so that's kind of the main reason we're here, I think, is just to refresh our care of the maintenance of the chest tube. Any troubleshooting that needs to occur, and then chest tube removal, because we hope at some point it will come out. And then what do we monitor post removal? So there's sign-in sheet. If somebody could write down Leslie's name and that she's on Zoom, that would be fabulous. And then make sure you do an eval at the end so you can get your CEU, and then the RNs can take a certificate and just write your name on it and you'll have your CEU. I'm trying something different. I've been emailing them out, but I think maybe this will help me be caught up because I'm kind of behind on it. And then the CNA certificate will come in a little bit. Very casual today. If you have any questions or whatever, just let me know. We'll just keep our patient names out of it if there's a scenario you want to discuss, since we are recording. So physiology review. Lungs are like balloons. We fill them with air, we ventilate, and they are in like a sealed cavity, much like this balloon inside of a bottle. And there is a space, you would agree, between the balloon and the sealed container. And this space is the pleural space. And what the lungs are very tissue-like, they're tissue paper-like, they're real thin and fragile. So if they were to just inflate and just keep beating up against this hard container, they would get damaged. So there's a tiny amount of fluid called pleural fluid that helps keep them lubricated and allows them to move slowly in and out as they ventilate inside of the chest. The fluid also creates something called surface tension, which keeps the lungs expanded and attached to the chest wall. If you've ever blown up a balloon and the balloon is completely deflated, maybe even all stuck together, like you find it in the back of a drawer, and now your kid wants you to blow up this balloon. So you're trying to blow up the balloon, right? And you can't get the air in because it's all stuck together and it's all deflated. The lungs are kind of like that. So if your lung gets totally deflated, it's kind of hard to blow it back up. And if you take something and shove a bunch of air in it really, really hard, you could pop a hole in it, right? As a nice to know thing is PEEP, the amount that keeps them just a little bit inflated so it's easier. So you know when you're blowing up that balloon and you get to that point where it's like, that spot, that's the PEEP. And so we normally have some PEEP as well. The pleural space also helps maintain negative pressure, which is essential to keep those lungs inflated, okay, during deep inspiration. So this is a picture of our inflated lung. This shows that itty bitty tiny space, pleural space, where that fluid is. And that's usually the area that is the problem or the fix, however you want to look at it, when we have a chest tube. So we'll just keep all those things in mind as we go along here. All right, so indications for a chest tube. If there's too much fluid, not just that little bit, or there's air, or there's blood, or there's pus, or something like that in that space, then the lung doesn't have room to inflate, and the lung is easily bullied. So the lung just deflates and lets that other stuff take up space. So we can have a pneumothorax where there's a hole in the lung, a hole in the balloon, and now we have air in that little space and the lung deflates. Or we can have a hemothorax, like if someone has a traumatic injury, like they're in a car accident or a bar fight or they get stabbed or whatever. Again, there's a hole in the lung, but now there's blood. Or we can have both, a hemopneumothorax. Empyema means there's pus in that space, so they develop an infection for whatever reason. When we have an infection, it makes all of our cells and tissues really leaky and kind of, they lose their integrity a little bit. So if somebody had a really bad pneumonia or something, they develop a pleural effusion, they could end up with an empyema situation. So what's the chest tube for? Well, it's going to use gravity or suction. It's a drainage container. And in order to get rid of the air, fluid, or blood that's in that space and allow the lung room to re-expand. Gravity works, but sometimes we need a little more oomph. The gravity's not quite enough, and so the suction just gives us a little bit more pull to get that stuff out. It's going to help restore the negative pressure, because once you pop a hole in there, the whole negative pressure thing goes away. Just like with a negative pressure room, isolation room. Once you open the door and leave it open, it's no longer negative pressure, and that's why it alarms, right? It's the same thing with the lungs if there's a hole, okay? And it doesn't allow the air to re-enter the lungs, because we only want the air going out in one direction so that lung can re-inflate. And it removes the material that's collected in the pleural space. So here's an example of a lung that's surrounded with some kind of fluid, and so it can't expand fully. So here's some pictures of what it looks like. Here's the chest tube inside of someone's chest. Of course, it's a drawing, but it gives you an idea of where the chest tube can be and why it's so uncomfortable. With every breath, it hurts because there's something in there that shouldn't be in there. And the chest tube itself is pretty stiff, pretty firm, and so it doesn't squish when you breathe. And then here it is on the inside. You can see the tube has holes, and we're going to do some hands-on later, but that's where the air or fluid will escape. And then this is what it looks like on the outside, and they put a couple of different types of sutures in there. I have another picture. I think it's a little more clear. One of them holds it in, the other one they use when they take it out. They can just pull it and it stitches it up, so to speak. Okay, so overview of the drainage system. Most nurses are going to call it a Pleurovac, even though Pleurovac is a brand name, but it's one of those things that just has kind of stuck. So when a nurse says they have a Pleurovac, it just means they have a chest tube drainage system, okay? It has 3 chambers. There's the drainage chamber that has 3 columns itself, but that's just to collect the drainage. There's always at least a little bit of blood, even if it's a pneumothorax, because they're stabbing a knitting needle, otherwise known as a trocar, into the chest, and there's gonna be a little bit of blood. So there's always gonna be a little bit of blood in your drainage chamber. As it fills, it spills over into the next column, and then the next column, and then now you're replacing it. There's a water seal chamber in the middle, and that is to prevent the air from getting sucked back in. And there's a suction chamber. It can be dry or wet suction, and that applies the suction force to pull whatever it is in there out. And then there's rubber stoppers on the back if you need to take samples or you've poured too much water in, okay? So here's what the Pleurovac looks like. So we've got the fluid chambers on the right, and you can see as it fills, it spills over to the next one and the next one. So if you trip on it, you kick it, you knock it over, it falls off the bed, whatever, this will all intermingle, and now you have to get a new one, which is why we generally tape it to the floor. You can hang it on the bed as long as it's below the patient's chest, okay? Because we don't want to pour things back into the patient. And then the water seal here, it has a line on it that tells you where you need to fill it. It usually says like 3 centimeters or something, but you just fill it to the line, and there is a thing called evaporation. So as the patient has the chest tube in for many days, the water will evaporate, and this will at some point need to be refilled to the line, okay? And then you have the suction control chamber. This is a wet suction picture. And so you're gonna fill to the line that the doctor has ordered. Almost always the doctor orders 20 centimeters of water suction. If it's something else, I would question it. If the order says 10 centimeters or 30 centimeters, I would say, are you sure that you didn't click the wrong button and you don't want 20? Because that's the norm. And then, or they'll say to gravity, in which case you just don't hook it up to suction. So this is a wet suction, and you can see the brand here, Pleurovac. So we're using sterile water. So every patient with a chest tube should have a bottle of sterile water in the room. It's for a couple of purposes. One is to initially fill your wet suction chamber and your water seal, and 2, to refill as things evaporate and as you need to like top it off. And 3, if the chest tube becomes disconnected from your drainage system, you can put the patient's chest tube in the bottle of water, and it's like a poor man's water seal until someone can grab you a Pleurovac because you're yelling that you need a Pleurovac, okay? So there, that's. Okay, then we have a dry suction water seal, and the only difference, we still have the drainage chambers, you still have a water seal, and you still have to pour water in it. You have this little dial here, and it points to the amount of suction that you are at, okay? And then when suction is going, this little red plastic thing, float, the float shows up in this window. So if you close the suction off, this will go away, and if you turn the suction back on, this will go. And you just have to trust that it is suctioning at, you know, what it says it's suctioning at, okay? So that's the only difference there. We also have Heimlich valve. So a Heimlich valve is just a one-way valve. And I have some of these that you guys can play with. Here's a couple of different, this one they're putting it in. You can see this part looks like a regular chest tube, but they attach it to this little device. This basically does the same thing that the Pleurovac does. It's just very small. The patient can't have a lot of drainage. It's usually for a pneumothorax, just to let the air escape. It's a one-way. It's portable, so it may be a long-term kind of a thing. And that's really all it's for. Otherwise, the care of it is the same. You just don't have to worry about all of those chambers and everything. Okay, so when we're inserting the chest tube, of course, we need informed consent that the physician does. This could be the intensivist, or it could be a cardiologist or a surgeon. Any of those people can put in a chest tube. We always have chest tubes after cardiac surgery, and then sometimes it's just a chest tube at the bedside, so it can be any of those kinds of things. Of course, we need an order. We're going to open that procedure tab in the M page, and that's where we're going to document everything, the timeout and the vitals and all of that. And so then you would follow your bedside procedure guide. Prepping the drainage system is probably the most time-consuming part. So it's all wrapped in a blue, like sterile wrap, but you just open it all up like normal, and the end of the tube has a cover on it. That's the part that has to stay sterile. The rest of it is just clean, okay? But you can see the end of the chest tube has holes in it, and they're different sizes. Every physician is different. They like what they like. Some of them I've seen take sterile scissors and cut more holes. If they know the patient it's gonna be a big hemothorax and maybe they expect a lot of clotting and they wanna try to prevent any of that, so they'll just cut more holes or they'll make the holes bigger. So if you see the doctor doing that, they're not crazy. That's why they're doing it, because they expect a lot of drainage. And then of course monitor respiratory system, including lung sounds, the pulse ox, and the site for bleeding, hematoma, and crepitus. So bleeding from the site, hematoma where there's bleeding under the tissue around the site, or crepitus, which is that air that gets under the tissue and it kind of feels like Rice Krispies. Although most of us don't like put our fingers in the Rice Krispies, I'm not really sure where that came from.
I think it's because of the way it sounds.
Like it feels the way
It's
like
it sounds.
Yeah.
It's weird, right? So anyway, so those are the things that we're monitoring. You might even want to turn on your audible sounds for your pulse ox, or your heart rate, so that you can kind of get that audible cue while they're putting in the chest tube. But for the most part, it's a pretty quick procedure. They're gonna just look at the x-ray, they're gonna put their arm up, they're gonna clean the area, probably with betadine, but whatever's in the kit. And then they're going to feel and count the ribs, and then they take out the trocar, they stab a big hole, they put their finger in there, they put the little pinchers in there and open it up, and then they shove, it's very brutal, they shove the tube in. So from a nursing standpoint, other than just monitoring that the patient is okay, we definitely want pain medication on board, if not something nice like Versed. Those things would be very helpful, because the doctor often just wants to get in there and be done. And we want the patient to be at least a little bit comfortable, okay? So yeah, it's pretty brutal to watch. So maintenance, we wanna make sure we have no dependent loops, because when you have a dependent loop, that's where the bacteria sits and grows and then climbs back into the chest, and now we have an infection. So this is a dependent loop, this is a dependent loop. And you're fixing your dependent loops probably every time you go in the room, because you fix the loop, the patient moves a little, the earth shifts, I don't know what happens, and the tube is now hanging down like that, and so you're just fixing it all day. No milking and stripping, I don't think that's even an issue today. Like, that used to be a big thing back in the 90s. You might see a doctor come in and do it because there's a big clot or something. If you see a clot in the tubing and it's not flowing, like it's just like a Foley. You want it to always be moving and flowing and not hanging down like that. So you can kind of go along and kind of pinch and move that clot along until it goes into the drainage system. That's fine. You just don't want to like be pulling it and milking it, stripping it, because that's what puts all that extra pressure in the chest. It can be really painful and you can cause some damage, okay? No lifting the pleura above the patient's chest. No clamping, no clamping. Because there's clamps at the bedside, number one, why the heck are we keeping clamps at the bedside if there's no clamping? And two, because we have clamps at the bedside, everybody wants to clamp, because I've got clamps and I feel like I should be clamping something. The only time that you clamp is when you're replacing the drainage system, and then it's for less than a minute, because you can cause a tension pneumothorax, which is where you have that excess air in the lung and it pushes everything in the chest to the side, including the trachea, and the patient could die because you're putting pressure on their heart and everything else, okay? So super bad, no clamping. And then you have to replace this when it gets full. When the drainage gets close to full and the patient is not crashing and everything is chill, that's when you want to change the pleura, okay? Not when there's like a space for 100 mLs left, okay? So while we're, no, I do have it on here. Okay, so then dressing change. So this has changed over the years, and it probably will continue to change. I reviewed the research because there's so many different things that I hear, but basically we're changing it every 7 days, or if soiled, or if loose, and we're cleaning it with CHG, betadine, or just sterile saline. So not the saline in the flush. We want to use the one in the bottle. You can just kind of put a towel under and just pour the saline on if needed, if it's kind of bloody or whatever. And then you're gonna put the split gauze, the drainage sponges, in 2 opposite directions, and then put a big Tegaderm on it. And you might even need to go get a big Tegaderm from the cath lab. They have ones that are like, they call them Costco size, they're like this big. And that way you can kind of see the site. And then of course label with date, time, and initials. And don't be afraid to change the dressing. It is sutured in, okay? And then of course monitor for your crepitus, air leak, infection, and bleeding. So when you have that site open, I would take a picture of it, especially if it's Wound Wednesday, just so you can monitor for infection and make sure it looks okay, and listen for an air leak. It should be sealed pretty good because it's sutured, but with a lot of movement and stuff, you know, it could come a little bit loose and you don't want to have any air leak. We no longer use the Vaseline gauze around the site because it damages the tissue. Okay, but you will see nurses doing that because that's the way I was taught, was to wrap that with the yellow Vaseline gauze. We're not doing that anymore, okay? Yeah, so we're just doing the 2 drainage sponges and a Tegaderm, okay? But don't start a fight if somebody's like, I'm using the Vaseline gauze, you know. And then they should have a daily chest x-ray. So if they did not have their chest x-ray or it wasn't ordered, go ahead and order it. And then if you go to CAT scan, you do not clamp it. You just unhook the suction and now it's to gravity. And you just go to your CAT scan and then you come back from your CAT scan, you hook it back up to suction, good to go. It should not be a difficult thing. So if you're stressing about going to CAT scan or MRI or whatever with your Pleurovac, don't. There's no need to stress about it, okay? And if somebody has it clamped, you unclamp it and you go talk to them and have a little discussion about no clamping. It's like we need the clamps in the room and we need a sign that says no clamping. It doesn't make any sense, but there it is. And then if the doctor just says, just put it to gravity, because you call and you're like, there's excess drainage, and they'll just say, okay, well just put it to gravity. And for some reason that also is a point of stress for nurses. It just means unhook the suction and just leave it alone. That's to gravity. This is what it looks like on the chest x-ray. So it's radiopaque, so you should be able to see it. And here someone has colored it in blue so you can see the whole thing. So nursing considerations, you need to have 2 clamps, not the little plastic green ones because they're not going to probably do anything. They should be the non-serrated, no teeth, because you don't want to cut through the tubing. They should be at the bedside, either taped to the end of the bed or taped on the whiteboard, but they always need to be in the room available. The petroleum gauze needs to be available for if the tube comes all the way out. Then you slap the petroleum gauze on, okay? It's yellow and slimy. It's only for accidental removal. It can macerate the skin and destabilize sutures. So it can cause a problem, okay? And then of course there should be a sterile saline bottle at the bedside at all times. All the connections need to be taped like this. You take that clear plastic tape and you do like 2 strips and then you do strips around. We used to tape with the pressure tape around all the connections, but then you can't see the connections. So we want to be able to see everything. So this is the best way. And actually, I don't do physics, but according to physics, this is like the stronger instead of just taping. And you can also do like where you tape like around, you know, like you tape it in one spot and then kind of go around the tube. You could do that too. But when I was researching it, this looked like it had the best outcome. Plus, if you're looking for an air leak, it's easier to untape. Okay, so you should have bubbling in the suction chamber. That's where you have the nice little babbling brook. It's not roaring rapids. So it should just be constant bubble if the suction is going. Constant bubbling in the water seal here means you have an air leak.
Is it
So,
regular or intermittent?
so constant bubbling is an air leak. Intermittent bubbling is okay. That's like from breathing. Tidling also, this will go up and down with their breathing. That's also normal. A couple of little bubbles now and then is fine. If it's a constant bubble, then you have an air leak. But when you first put the chest tube in and you have a pneumothorax, the air's leaving and you want it to leave so the lung can re-expand, you expect an air leak. An air leak is normal when you first put the tube in. If the chest tube's been in for 4 days and now you have an air leak, you have a problematic air leak. If it's only been in 24 hours, maybe 36, and you still have an air leak, you're gonna chart you have an air leak, but it's probably normal because the air is leaving that space so that the lung can re-expand. And then you would put that information together with what the chest x-ray looks like. If you have an air leak and your lung is still showing not fully expanded, those things go together, makes sense, right? If you have an air leak but your lung is showing fully expanded on the chest x-ray, there probably shouldn't be an air leak because it's fully expanded now, okay? And what you're gonna do is you're going to start at the insertion site and you're gonna just pinch the tubing and watch when the air leak goes away and just go down the tubing until you find it. When you pinch and the air leak stops, it's somewhere above where you've pinched. And so you either need to tape it up or redo the dressing, try to figure out, maybe you have to change the whole drainage system. It just depends on what you find when you're investigating. And then of course pain medicine, because that tube hurts all the time with every breath. Not so much pain medicine that they won't take a deep breath. Did you have a question, Angela?
You know, like when it's on a suction thing,
Mhm.
is it turned to the regular? Or
Yes,
is it,
the suction on the wall
Yeah.
will say regular.
Right.
And then there's not a number you're looking for, you're just gonna turn it down until the bubbling is just a steady bubbling in the suction chamber,
Okay.
not the water seal.
Right.
Yeah. Okay? It's just kind of a visual audio thing.
Okay.
Yeah. Cause some patients, the number is really high and some it's really low and they have the same bubbling. So when do we notify the doctor? If we have greater than 200 mLs in 1 hour, including bleeding. If the chest tube gets displaced, like this poor fella, he has some sub-Q emphysema. And then if the chest tube gets accidentally removed, which is not a nice call to have to make. If they're having shallow, rapid breathing, they're turning blue, they're having swelling, whether it's air or a hematoma. If they develop chest pain, like different chest pain, not the normal pleuritic chest pain that comes with having a tube in there and breathing, okay? Or like Mrs. Puff, she's all blown up there. Has anybody had a patient that looks blown up?
I've seen it.
Yeah, I had a trach patient back in the day, and it was the middle of the night because I worked night shift, and they were having respiratory distress, and so we hooked up the ambu bag to their trach, and we were bagging them, and with every time we would bag, and so I was across the bed from the RT, and we're just looking at each other, and then we're looking at the patient, and we're looking at each other, and we're like, oh my God. So I called the doctor in the middle of the night, and I said, my patient is blowing up. That's what I said. I was a fairly new nurse. And he was like, okay, well just call anesthesia and get them to intubate, orally intubate. And then they came in, and then he drew me a nice picture on the wall of what it looked like when the trach gets dislodged and what had happened. And my poor patient, she couldn't open her eyes or anything. She looked just like this for several days. But she was alive, she did okay, but I felt really bad. This was back before the intensivist days. All right, other troubleshooting, if you have leaks, if you have that constant bubbling in the water seal, you're clamping, meaning with your fingers, you're pinching until you find the leak. And then, of course, change the tubing or the dressing, depending on what you found. If it gets dislodged, of course, you're gonna notify the provider, you're gonna get a chest x-ray, and I'm gonna see if my video will play. So that's what it would look like constant. If the drainage system gets disconnected from the tube, we already mentioned this, but you're gonna just put it into the bottle. If you don't, like if the bottle's across the room and there you stand and you're like, oh my God, just pinch it, because you just don't want the air to get sucked back in, because then you're gonna like be starting over with another pneumothorax, okay? So yell for help, pinch that chest tube, it's just gonna be for a minute. And then stick it in the bottle until you can get another Pleurovac that's ready to go, all right? Accidental removal, if the whole thing comes out, other than ordering the sitter, because the patient's like, here's my chest tube. Cover the insertion site, you know that happens, right? Cover the insertion site, and ideally with something sterile. Hopefully you've got some sterile gauze or something in there, but if all you can do is cover it with your hand, that's what's gonna have to be. And just for a minute, and have them, if they were like breathing in when you did it, you can lift your hand, have them breathe out, and then recover it, because you wanna try to have it where the lung, is in the right breathing pattern. Not accidental removal, is going to happen when the fluid that's coming out has decreased to an acceptable level, whatever the physician or provider says is acceptable. There's no air leak, there's no empyema, it's messy. Make sure you bring a chuck or a towel, because depending on your provider, they're just gonna,
Snatch it out and go.
and fling, right? So just get out of the way, don't be right next to it. And at least slap a towel or a chuck right underneath them. But you should have an idea it's gonna come out, because when you get report, you're like, oh, it's been in for a few days, I don't have much drainage, let's see, maybe it's gonna come out, so I'm gonna just have my stuff in the room for when the doctor comes in. And then you'll need an occlusive dressing, so you're gonna put a little petroleum jelly and a gauze on it, because it should only be for, a day or two that they need the dressing. Here's the better picture. You're gonna cut this suture. I mean, the doctor's probably gonna do it for you, but you need to have that kit with the sterile scissor. So they're gonna cut here, and then here they have a purse string, and they can just pull the ends of the string, and it like closes the hole. It's kind of a cool little way to do it. And then of course, the next 4 to 6 hours, you wanna make sure the patient doesn't develop another pneumo or problem from the chest tube being out. You're gonna look at their breathing effort, their pulse ox, are they coughing, do they have secretions? Look at your dressing, is the dressing soiled? Because maybe they need another chest tube. You can always get a chest x-ray just to see where they're at. Okay, any questions, Leslie? We're gonna do the hands-on part. Okay, thanks. Okay, so I'm gonna leave my thing still recording so I can do this part. And then we'll stop it. And you guys can play around with it. Okay, so we've got our water bottle. We've got our trocars, and whenever the doctor asks for the trocar, you'll just, read the label to see what size it is. And this is what the trocar looks like. This is what they stab into your chest, and then they pull that part out, and the plastic tube is over the top. This one must not have a tube. yeah, neither one of these has the tube in it. So there's those you can look at. Here's the, yeah. These are Heimlich valves. So we can take those out of the package and you can have a look at those. This is like a fully together kit. This is what it looks like. And then we've got a couple of different, Atrium is this brand, right? This is the tubing, and then it comes with the cover, and that's where you take that part off, and the doctor's doing their thing, and you're charting, and then of course I'm not gonna be able to, yeah, you pull this off, he's gonna have the tube, and you're just gonna meet him, you know, part way and push this in, because this part has to stay sterile. Okay, it's got little hooks, so you can, I'm not missing a hook. It's got little hooks you can hang on the end of the bed when you go to CAT scan. There's usually a little foot at the bottom that will, you can open, and then we usually put the tape across here. You have to be real careful. I've been known to crunch a chest tube drainage system with the bed, putting the bed up and down. So if it's like under the bed and you're trying, like, why won't my bed go down? You're probably, it makes a noise. You're probably smushing this, so just be aware. And then at the top, you've got a little stopper, and that's where you're gonna pour your water in, okay? So you guys can practice doing that, but you'll pour your water in, and then you'll see the suction where you're pouring it to, there's a line, and then the water seal, there's a, you're gonna pour it in here. You can put a syringe if you want and pour the water, and there is a little knob you can turn to like stop it. And that will put the water in your water seal, and there's the dotted line, and then your drainage that comes from the patient in the 3 chambers. And then this is a little bit older version. I kind of like it because it's kind of big and clear, right? So same kind of thing, your suction, you just fill it up to 20. When you guys come in to assess your patient, so obviously you're going to assess the respiratory status, you're going to assess the site, all of those things. But you'll have your suction attached here, and there's an arrow, and it says right there, attach your suction. Okay, so that's like a no-brainer. There's a hole here to pour water in for your suction, and it tells you right there what it is. And then this one is a little cap that you can pour for your water seal, okay? And obviously you just wanna keep that area as clean and sterile as you can because it connects to the chest. But when I come in and I assess my patient and I wanna assess all the levels of everything, I just pinch my suction and the bubbling will stop. And then you'll see, oh, I don't have 20 of water, but I've looked at my order and I know it's supposed to be at 20. So I'll just take my water bottle and just pour a little bit more in. And then I'll just turn my suction back on by unpinching. So that's just kind of how I assess that part. Okay, and then this one's the same. And then we've got some clamps that you can look at. And this, I think, is the removal kit. And then we have a Pleurex. Pleurex is similar to a chest tube. We use this a lot for hospice patients when they need like frequent draining of their chest. And basically they have a tube, yeah, and it has a little connector, and you just attach it to this, and when their chest starts to hurt, you stop. Or bleed, or yeah, or look bad, right? And so they can do this at home, so the family can be taught to do that. So if they have a Pleurex drain, one, you're thinking to yourself, okay, this is some kind of end stage, some kind of, you know, sad, awful situation. And two, they're gonna need, I would have the family do it once they've been taught to do it. If I came in to drain their chest, I would say, okay, let's do this together, because the family's gonna have to do it at home. Okay? And then make sure that we document all of that. All right, any questions? We good? Okay, I'm gonna stop the recording and then you guys can play with the equipment.